Good evening, friends. I am Dr. Agam Vora from Mumbai, and currently I hold the position of Governor, West Zone, Chest Council of India. At the outset, I must express my sincere thanks to my dear friend, Dr. N.H. Krishna, and of course, the entire Chest Council of India for realizing the need of doing this program. And I thank both the guest faculties, that is Dr. Pratibha Singhal and my close friend, Dr. Swapnil Kulkarni, who agreed to be part of this particular program. We are going through very tough time. A small 100 nanomicron particle is threatening mankind. We are supposed to be the most evaluated species on the earth, that is Homo sapiens, are at threat. Already 1.5 million patients are diagnosed having coronavirus infection across the globe, and we've lost more than 1 lakh lives already. In India, scenario is getting grim. We are going to be seeing more number of patients infected with disease and more mortality in time to come. But luckily, as of now, the disease seems to be under decent control. And as all of you are aware, it affects mainly the patients with underlying abnormal immunity, and mortality is maximum in patients with underlying abnormal respiratory system. And the commonest illness that we have is COPD when we talk about non-infectious causes. COPD, if we go by various figures, 3% of Indians are suffering from COPD, and even if we take it as 100 crore Indians, we are talking about 3 crore COPD patients in our country. And 40 to 70% of these patients we lose, depending on the severity, in next 5 years. So we are talking about a huge burden of disease that we have amongst our country. And to talk about this particular disease and the management, we have with us Dr. Pratibha Singhal. Pratibha is my very close friend, and her friendship goes beyond probably 2 decades. She is a consultant chief physician and interventional pulmonologist at Bombay Hospital and Sir H.L. Reliance Hospital, Mumbai. She is currently the secretary of Interventional Pulmonology Group by ERS, and she holds this position since September 2018. She was lecturer at Science Hospital, and I had the fortune of working with her that time. She is awarded fellowships for training in pulmonology, EBUS, sleep medicines, and fluoroscopy at Cleveland Clinic, Ohio, and then at NHU, Singapore. She has chapters in many national and international publications. She is faculty at various national conferences and done a lot of bronchoscopy workshop. She's organized interventional pulmonology workshop, which is a huge success and one of the most favorite workshops that she conducted during NAPCON, which we hosted in 2016 at Mumbai. So without wasting much time, I present Pratibha to you. At the same time, I thank the education partner, that is Juventus, and I'm closely associated with Juventus for again more than 2 decades, and I thank you for your educational support.
Good evening, friends. It's good to connect with you. So today we are going to discuss COPD, current issues and OPD. First of all, I'd really like to thank CCI Chest Council of India, Dr. N.H. Krishna, who is the brain behind it, Agam, Narayana, the whole CCI family and all friends and well-wishers and all of the people who have logged in. Why are we talking about COPD? So we all know that COPD is the top 10 leading causes of death in Maharashtra. Well, of course, currently the scenario is kind of changing with Maharashtra being on the front with the number of COVID-19 cases. So why are we talking about COPD in the current COVID-19 pandemic? We know that patients with underlying respiratory conditions are at risk for catching an infection with COVID-19. Also, there are certain other common risk factors. You have COPD patients are older. Again, COVID is known to affect the older population. Smoking, which is seen in COPD patients, again is a risk factor for COVID-19. And of course, COPD patients do have existing cardiovascular comorbidities, which is also again a risk factor for COVID-19. Now we know that the definition of COPD says that COPD is a common preventable and treatable condition that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. Why are we talking about this definition? Because we know that to diagnose and initially assess COPD, sorry about that, to diagnose and initially assess COPD, we have to have a strong clinical suspicion that means you have a patient older than 45 to 50 years who has dyspnea, chronic cough, with or without sputum production, and in history of known exposure risk factors like tobacco consumption or occupational exposure and indoor-outdoor pollution, biomass fuel exposure. And therefore, in such patients, we usually advise a spirometry to establish diagnosis, where the post-bronchodilator FEV1 is, if it's less than FEV1 by FPC is less than 0.7 is when we consider it to be COPD. However, in the current scenario, okay, we will have to figure out whether we are really going to look at the spectrum of COPD as what is defined by GOLD. So another thing that I want to make sure is that and stress is that we don't always need to physically see the patient, and a telephonic consultation or a video consultation is the way to go currently. In this current scenario, okay, I think avoiding PFT, it would be of prime importance, and therefore assessing the risk of COPD and the classification of COPD based on the GOLD ABCD group is probably of prime importance. So what do we have in the ABCD group is we have the risk categorization by the number of exacerbations, and we have the symptom score, which the common scores that are used are the CAT score and the modified MRC score. So you have the category A, which is low risk, less symptoms because they have less exacerbations per year and less symptom score also. You have category B with low risk but more symptoms where they have had less than one or only one exacerbation per year, and the category CAT score and the MMRC score is high. You have category C where they are high risk because they have had 2 or more exacerbations in the last year, but they have a less symptom score, and of course the category D, which has high risk with more symptoms. Now, managing stable COPD has not changed during this COVID pandemic. It remains the same. It will be based on once a diagnosis has been made, individualized treatment, and to decrease the risk of future exacerbations. So what are we treating currently? What we are doing is based on the category of ABCD. In category A, you give the patient a bronchodilator. In group B, you give a long-acting bronchodilator, a LABA or a LAMA. Group C, LAMA is advised. And in group D, you give a LAMA-LABA combination. And ICS is added if patient has high symptoms or more exacerbations per year, or if the baseline eosinophil count is more than 300. So this hasn't changed much. In the current scenario, you are still going to treat new patients in this categorization, and you're going to follow them up based on this categorization. The important thing that GOLD 2020 has changed is that they have classified and given very strict criteria about when to consider initiating ICS treatment for a stable COPD patient. So the important thing to note is that when patients remain symptomatic despite appropriate long-acting bronchodilator maintenance therapy is when you would consider initiating ICS. So strong evidence is when you have had a history of hospitalization for exacerbations which have been more than 2 moderate exacerbations, blood eosinophil levels of more than 300, or there could be a concomitant asthma-like history. Use is advised when you have had one exacerbation and blood eosinophil levels between 1 to 300, you could consider it. And against when patients have had repeated pneumonias, or there is a blood eosinophil level of less than 100, or there is past history of TB infection. Now, what do you do for follow-up pharmacological treatment? I know there must be patients who must be calling up, who are getting anxious because they cannot see their doctor. I know it's happening to my patients, and they're calling up and saying, doctor, when can we come for follow-up? Because you had asked us to come for follow-up after 2 months. So, of course, we are not seeing patients physically. We can do a telemedicine consult, review their symptoms, check if they have any improvement in dyspnea or worsening of dyspnea. Look, ask about if there has been any recent mild exacerbation. Assess the inhaler technique. Here we can use the help of YouTube to send them links to confirm, and so that they can relearn how to use their inhalers, and any adjustments are made based on their symptoms if we need to escalate any medications or change inhaler devices. Vaccination. Okay, this is another important question that is coming up from patients and the public at large about vaccination during the current time. We know that for COPD, influenza vaccination can reduce serious illness and death in patients, and pneumococcal vaccinations, the PCV13 and the PPSV23 are recommended for patients who are older than 65 years. In the current pandemic, patients who haven't received the influenza vaccination should receive it, and due doses of pneumococcal should be given. There is no evidence to say that unless the patient is having an acute exacerbation, do not give these due vaccinations. Another important thing is that you can ask patients to arrange for a finger pulse oximeter at home. It's readily available. Arrange an oxygen concentrator at home for patients, and prescribe supplemental oxygen to patients if they have saturations less than 88%. Titrate the oxygen to keep the saturations above 90% and review these patients. Now, what has GOLD said? GOLD, which is like the Bible for COPD, doesn't have much to say about COVID-19, and what it says is there is no scientific evidence to support that ICS, OCS, that is inhaled corticosteroids or oral corticosteroids, should be avoided in patients with COPD during COVID-19, and regular therapy has to be continued. But let's look at what happens practically to our patients and what difficulties we face when patients are calling us up and giving us symptoms that sound like an exacerbation. So what do you mean by an exacerbation? We know that COPD exacerbations are defined as an acute worsening of respiratory symptoms that result in additional therapy. So commonly patients come with increased cough, breathlessness, fever may be there. If they have mild symptoms only, then we usually land up treating them only with short-acting bronchodilators. Again, here important, avoid nebulization at home, advise to escalate their inhaler with spacer, and you can ask patients to use YouTube to understand how to use inhalers. Moderate exacerbations traditionally are treated with short-acting bronchodilators plus antibiotics and or oral corticosteroids. So here let's look at practically what will help us decide what to use in this current scenario. We know that the absence of previous high eosinophils suggests a pure COPD phenotype, and patient is less likely to respond to steroid therapy. Avoid home nebulization. Antibiotics, if needed, if patient has fever, purulent sputum, give a broad spectrum antibiotic like an amoxiclavinate or even third generation cephalosporins like cefditoren. Add azithromycin because not only cover 8 infections, it also has additional COVID-19 cover as well. And if patient has an influenza-like illness, give oseltamivir also. Now, what happens to severe patients? Patients who are breathless, who require hospitalization, who have drowsiness, who are, who visit the emergency room. They currently come under the spectrum of severe acute respiratory illness. So, it is important here to clinically remember that all SARI patients do not have fever. So, please don't think that if patient has no fever, it could still not be COVID. Sorry about that. Treat all emergency admissions as COVID-19 suspects in isolation area with, until they are proven negative with a swab. Some investigations which can help us when patients get admitted to figure out whether it could be a viral COVID infection versus a bacterial infection. Lymphopenia. Okay, we have evidence from around the world, and there is enough evidence from our country also from centers treating it, which says that patients with COVID, there is 80% of patients with COVID infection have lymphopenia. They also have mild thrombocytopenia, and usually lymphocytes are not less, platelets are not less than 1 lakh. They also, if there is a raised CRP as high as 41, it has a very high sensitivity of 90% and a specificity of 77%. PCT, procalcitonin, if it rises between the range of 0.1 to 0.5 is highly suggestive of viral infections. More than 0.5 is most likely bacterial. D-dimer has also been seen to be high in COVID-19. So please, if you are in doubt about whether it is a bacterial infection or a viral infection, please send these labs and which can help guide you. because it is also seen that sometimes patients have negative swabs, can have initial negative swabs even with very typical presentation of a COVID-19. HRCT in COVID, if you have a doubt, if you have negative swabs and if you're in dilemma, only when you are able to do it in a center which has adequate isolation and protection for the healthcare workers. The classical picture is lower-low predominant peripheral GGO with septal thickening. Remember, if you have patients with lobar consolidations, dense consolidation, or you have patients with cavitary disease, or you have patients with tree in bud appearance, there is more than 70% concordance to say that it is less likely to be a COVID infection. So look at other etiologies. How do we give oxygen to these patients in the hospital? So this is interesting information because we need to know whether what device to use, whether to use a nasal cannula or a mask or a V mask or a non-rebreathing mask. So let's look at what is the data on the maximal exhaled air dispersion with various techniques. With nasal cannula at 5 liters, it is as high as 100 centimeters. Oronasal mask at 4 liters, it is 40 centimeters, the air dispersion. And with V mask at 40% is 33 centimeters. With a non-rebreathing mask at 12 liters, it is negligible. So the important thing is that we should be using non-rebreathing masks at 12 liters. If patients, because we know that COPD patients with exacerbations very often have carbon dioxide retention, please do an EBG at admission when they are coming in severe breathlessness. NIV should be used during exacerbations. Again, there is enough evidence to say that non-invasive ventilation also has a high exhaled air dispersion, and therefore it causes a lot of aerosol droplets, and therefore can be increasing the risk to healthcare workers. So let's look at what an NIV with full face mask. The exhaled air exposure distance is 92 centimeters, which is high. NIV with helmet without a tight air cushion with high IPAP pressures of 20 and EPAP of 10 is 27, and NIV helmet with tight air cushion is negligible. So the one to use is NIV helmet with tight air cushion, but I think availability in our country is an issue. So therefore, when you are in doubt, when you have a patient who is not improving on oxygen with non-rebreathing mask and you have a patient with CO2 retention, it may be better to just ventilate these patients. Again, invasive ventilation, I'm not going to go into the exact details of all the techniques and all the methods. Some points which we should remember: intubation with a video laryngoscope, preferably through a hood to decrease the exposure to personnel. Avoid nebulization again. Use inline circuits with MDI adapters. For example, this is a inline nebulization adapter, but this has also been loaded with an additional adapter for the MDI. If no inline circuits are available, then and you have to use nebulization, then you should clamp the endotracheal tube while attaching the nebulization to decrease the aerosol spread. Always use inline suction again to decrease the aerosol spread, and IV steroids if necessary. Some positives, at least what I'm seeing in my practice, is that I'm seeing that in this last week, less patients are calling up with exacerbations. Could be probably because of less environmental exposure. It could be because of less pollution, maybe social distancing, and that's why they're not getting exposed to other people with infections, and just healthy eating, sleeping better. Some positives also in this whole scenario. This is an interesting data which tells us about air pollution at Delhi, and if you can see that the day before the Janta curfew, the air pollution was high. And if you can see today, this of course is data from a little while ago, and I borrowed the slide from Agam. Thank you to him. It says that the particulate matter is much lesser, and it's only 26.9, and the normal levels are 60. And therefore, this could be one of the reasons that we are having a less incidence of exacerbations in the country. To summarize, okay, so avoid PFT for diagnosis in new patients, rely on history and symptoms. and categorize them as per the ABCD. Use telemedicine for stable patients. Avoid visits of patients to the hospital unless absolutely necessary, because to decrease their exposure and as well as your inadvertent exposure, because we know that in Mumbai itself there have been many hospitals, and I know there are hospitals around the other hospitals around the country as well, where inadvertent exposure to healthcare workers have and admitting COVID patients inadvertently has resulted in sealing off of hospitals and therefore stopping all work. And of course, we are exposing ourselves to risk too. Stable COPD patients continue regular medicines as per the categorization. Oral corticosteroids, caution use in exacerbations. Do not use for the COPD phenotype because it is less likely to cause improvement. Avoid nebulization even at home for patients with exacerbation to decrease aerosol spread to their family members. Antibiotics, add azithromycin during exacerbations. Consider severe exacerbations as severe acute respiratory illness and as a COVID suspect even in absence of fever. Keep them in isolation, send the swab. All hospital admissions to be COVID suspect until proven negative. CBC, CRP, Procal, D-dimer to be done on admission for exacerbations. HRCT when feasible, especially when in dilemma about COVID-19 infection causing an exacerbation. Avoid nebulization in ICU. NIV only with the NIV helmet with tight air cushion, and oxygen with non-rebreathing mask to decrease the aerosol spread. With that, I thank you and I hope all of you stay safe.
Thank you, Pratibha. That was indeed a wonderful presentation. You've touched upon various issues that we face in managing COPD in day-to-day practice, and probably your message on managing stable COPDs and the concern that we have is really apt. We move on to the next topic, and the next topic is approach to infections transmitted as droplets with respect to bacterial and viral infections. And we've been talking a lot about this droplet infections and airborne infections, etc. And to give us details of this, we have my close friend Swapnil Kulkarni. I had the fortune of working with Swapnil when we had the first CCI con in Mumbai, and I must tell you, very enthusiastic, very hardworking guy. Currently working at KM Hospital Pune and Joshi Multi-Specialty Hospital and Ratna Hospital there. He's co-authored a very interesting chapter, and that is spirometry in normal individuals, who was establishing a new prediction equation, and he also presented this poster at European Respiratory Congress in 2016 at London. He's presented papers on study of sputum differential counts in asthmatics, controlled and uncontrolled inhaled corticosteroids at 234th research meeting of Medical Research Center, Bombay Hospital Institute of Medical Sciences and Researches, and has presented posters on recurrent pneumonia in patients with endobronchial valves in BronchoCon 2016 at Integra, and won the second prize. I present Dr. Swapnil Kulkarni to you.
Myself, Dr. Swapnil Kulkarni. I am a pulmonologist from Pune, Maharashtra. For this webinar, I would like to thank Chest Council of India, entire Chest Council of India, President Dr. N.H. Krishna, General Secretary Dr. Narayana Pradeep of CCI, entire founder members of Chest Council of India, Dr. Agam Vora sir for making this happen, Team Juventus and Team Science Integra. So I'll be talking on droplet infections, various droplet infections, and how to differentiate present virus of interest, that is COVID-19, from these droplet infections. So we'll start. When I was preparing this talk, I came across very interesting branch of science, which is known as aerobiology. Aerobiology is the study of movement of microorganisms through atmosphere from one place to another. Well, droplets, the aerobiology focuses on droplets. So droplets consist of mostly water with various inclusions depending on how it is generated. So depending on the process of generation, they are classified into two types. First, naturally produced. Second, artificially produced. Naturally produced droplets are produced by activities like breathing, talking, sneezing, coughing, even singing. while artificially generated droplets are produced at healthcare settings. They are produced during procedures such as nebulization, suctioning, intubation, cardiopulmonary resuscitation, etc. Droplets which are more than 5 micron in size tend to remain trapped in the respiratory tract, while droplets less than or equal to 5 micron in size have the potential to be inhaled into the lower respiratory tract. We'll quickly go through some definitions. Droplets are particles more than 5 micron in diameter. They fall rapidly to the ground under gravity, so are transmitted only over a limited distance, that is less than 1 meter. While droplet nuclei are particles less than or equal to 5 micron in size that can remain suspended in air for significant periods of time, allowing them to be transmitted over a distance of more than 1 meter. This is the reference for these definitions. We all know how droplet transmission occurs. When an infected person coughs, sneezes, talks or sings, tiny microscopic droplets of organism-laden aerosols are released into the air. Some of them remain suspended in air. Some of them, because of gravity, gets deposited on surfaces and remain viable on those surfaces for a certain period of time. When another person comes in contact with such an environment, droplet transmission occurs. We just saw various types, various methods or various procedures which leads to release of particles into the air. These natural activities, these are various natural activities. An approximate amount of particles which are released in air through these activities. We'll see what is the number. Sneezing is most hazardous. Approximately 40,000 particles are released in the air per sneeze. While coughing, around 710 particles are released in the air per cough. Talking also releases around 36 particles in air per 100 words of a talk or conversation. So be careful while talking also. This is very interesting table. I adopted it from a recent review published in European Respiratory Journal. It shows common procedures which we do regularly in our hospital setting, and amount of particles, the distance, the particles which are released into the air through these procedures, and the distance to the extent to which these particles are released, the maximum exhaled air dispersion distance through these procedures. So simple oxygen supplementation via nasal cannula results in dispersion of particles up to 100 centimeter, that is 1 meter. But if we use a simple face mask for oxygen supplementation, then this distance drastically gets reduced to 40 centimeter. Similarly, if we use Venturi mask, then this distance further reduced to 33 centimeter, that is just about 1 foot. And if we use non-rebreathing mask, then this distance significantly gets reduced to less than 10 centimeter. Similarly, for CPAP and NIV, if we use CPAP with oronasal mask, then there is negligible air dispersion of particles. If we use CPAP via nasal pillows, then it is around 33 centimeter. High flow nasal cannula, if it is properly fit, then dispersion is around 17 centimeter up to 17 centimeter. And if it is not properly fixed, then up to 62 centimeter. NIV via full face mask, dispersion is up to 92 centimeter. And if we use NIV via helmet through tight air cushioning, then the dispersion is negligible. We know the sum of the droplets, some amount of droplet gets settled on surfaces, and the organisms in those droplets remains viable for certain amount of time. This table we will see this approximate survival time for microorganisms on hard inanimate surfaces. Adenovirus can survive up to 3 months. We know our COVID-19, the present pandemic, The COVID-19 virus can survive on copper surfaces up to 4 hours, on cardboard surfaces up to 24 hours, that is 1 day, on stainless steel surfaces up to 48 hours, 2 days, on plastic surfaces up to 72 hours, 3 days. MRSA can survive up to 7 months on hard surfaces. And Mycobacterium tuberculosis, which we commonly see many patients of tuberculosis in our practice, the Mycobacterium tuberculosis can survive up to 4 months on hard surfaces. So, I would suggest we should continue our present habit of cleaning desks, OPD tables with disinfectants even after this COVID scare is over. Look at the Mycobacterium tuberculosis. It can survive up to 4 months on hard surfaces. This is the list of infection which spreads through droplets: coronavirus, influenza virus, Haemophilus influenzae, Group A streptococcus, diphtheria, pneumonic plague, Staph aureus, rhinoviruses, respiratory syncytial viruses, Mycoplasma pneumoniae, Neisseria meningitis are some of the infections which can spread through droplets. But that list is very long. But our interest is how to differentiate COVID-19 from these other droplet infections. Now we'll see that under these 3 headings: how to differentiate COVID-19 based on clinical profile, how to differentiate COVID-19 or how to suspect COVID-19 based on laboratory profile, and how to suspect COVID-19 based on radiological profile. We'll see one by one. So clinical profile, as we all know, influenza-like illness, that is cough, cold, sore throat, fever, etc. are very common to many droplet infections. But these two, that is anosmia, loss of sense of smell, ageusia, loss of sense of taste. These two are emerging as significant initial symptoms, or in some cases only symptoms, through various studies. So anosmia and ageusia, we have to look for these symptoms. Lab profile, leukopenia and lymphocytopenia is very common among COVID positive patients. The following two are the ratios which are predictor of severity of the disease. So first is neutrophil lymphocyte ratio, or NLR. It is a simple ratio of absolute neutrophil count to absolute lymphocyte count. If this NLR is more than 3.13, in one study they have taken this as a cutoff, and they found out that if NLR is more than 3.13, is a predictor of severe disease. Similarly, LCR. What is LCR? LCR is ratio of absolute lymphocyte count to C-reactive protein value. So this ratio, LCR, lower the LCR, more is the probability of severe disease. This is through a meta-analysis by Francisco Alejandro et al. Eosinopenia, there are few papers have come up which have shown eosinopenia as a very strong association with COVID positivity. So eosinopenia, that is less than 0.02 into 10 raised to 9 per liter, is very strongly associated with COVID positivity. In these two papers, they found out that eosinopenia is present even more commonly than leukopenia and lymphocytopenia. Procalcitonin is often normal in COVID-19 infections. The other acute phase reactants which are commonly elevated in COVID-19 are C-reactive protein, serum ferritin, D-dimer, lactate dehydrogenase, LDH, and CPK. We'll come to radiological profile, features, characteristic of COVID-19 infection. X-ray may or may not be normal. When it is abnormal, most common findings are bilateral peripheral patchy consolidations or granulous opacities. On high resolution computed tomography, HR-CT scan, bilateral peripheral GGOs with crazy paving, reverse halo sign or atoll sign is commonly found in COVID-19. So there are certain features which are against COVID-19, which are pleural effusions, lymphadenopathy, and drain bud opacities. So these features are very much against COVID-19 infection. So to summarize, what are the take-home messages from this discussion? Droplets are generated both naturally as well as artificially. For us healthcare workers, artificial generation is very much important. So I would suggest we should ban blanket use of procedures like nebulization in our practice. Droplets by definition are more than 5 micron and droplet nuclei are less than 5 micron in diameter. Sneezing releases maximum number of particles in air. Choose your oxygen delivery system very carefully for your patient to limit the spread of droplets. Venturi masks, non-rebreathing masks are better than simple nasal cannula. Loss of smell or loss of taste can be the earliest symptoms of COVID infection. Eosinopenia is found more frequently than leuko or lymphopenia in COVID patients according to few studies. CT features against COVID infection are pleural effusions, lymphadenopathy, tree in bud opacities. Last but not the least, as we all know, there is no foolproof treatment available for COVID-19 infection at present. Protection is the only cure. Protection is the only first-line treatment available for COVID-19 at present. These two pictures, first picture is self-explanatory. Probability of contagion, as we can see here, if everybody uses mask, then probability of contagion is low. In second picture is my friend Dr. Hare Krishna VAP powered air purifying respirators to protect. That is a foolproof or that is a very advanced personal protective equipment. So baseline is use PPE. I would like to end this talk with few questions. Obviously, I am only going to answer, but you all can think about it. So first question is, what is more infectious, sneezing or coughing? What is more infectious, sneezing or coughing? No, answer is sneezing, as around 40,000 particles are released in air through or per sneeze. Second question, what will you prefer if your patient needs oxygen supplementation? A, nasal cannula, B, face mask, and C, Venturi mask. The answer here is Venturi mask. I would like to again go to the same table. As you can see, the maximum exhaled air dispersion distance if oxygen is supplemented by a Venturi mask is 36 centimeter, while it is 100 centimeter via nasal cannula and up to 40 centimeter via face mask. Next question, which of the following has maximum survival time on hard surfaces? A, COVID-19, B, influenza, C, Mycobacterium tuberculosis. And rightly guessed, answer is Mycobacterium tuberculosis. This is the slide for that. As you can see, Mycobacterium tuberculosis can survive up to 4 months, while COVID-19 up to 3 to 4 days, and influenza up to 1 to 2 days. Which of the following CT finding is against the diagnosis of COVID-19? A, peripheral consolidation, B, pleural effusion, C, crazy paving, and D, GGOs or ground glass opacities. And the answer is pleural effusion. As we all know, pleural effusion, lymphadenopathy, and tree in bud opacities are against the diagnosis of COVID-19. So I would like to end this question. I would like to end this with this question. Best worst question I was asked about COVID today. I came across this in Twitter. You can read the question. Obviously, I am not going to answer this. Please don't ask this question to me in question answer session. You just read it and think over it. After all, not all coronas are bad. Thank you.
Thank you, Swapnil. That was really fantastic. You cleared a lot of doubts about this droplet infection and airborne infection, and especially when the current times when we are talking about COVID infection as being droplet infection versus airborne infection, and the relevance has always been there when we're treating tuberculosis for decades together. I thank you for your fantastic talk. And as I can see, there are a lot of questions already piling up, and I request both of you to take up these questions. Accordingly, depending on COPD questions will be answered by Pratibha, and the queries regarding the mode of transmission regarding bacterial and virus infection, droplet versus airborne will be taken by Dr. Swapnil. Thank you.
Sir, we can start. Sir, unmute.
Thank you everybody for watching this and for your questions. So we'll take questions one by one. First question is for me, by Dr. Sandeep. What is the alternative for nebulization? So Dr. Sandeep, I would say, as I told, we should restrict the use of nebulization. We should ban the blanket use of nebulization. As we see many a times, many MOs and doctors start nebulization without even checking the patient. Just patient is having breathlessness and nebulizations are started. So first confirm whether there is any need of it. If at all needed, then we can use any MDI with a spacer device to prevent the spread through aerosol transmission.
Can I add something to this?
Yeah, sure.
Swapnil?
Sure, ma'am. You can.
So, just to add to this, Sandeep, for COVID-19 admissions in the ICU with severe breathlessness, most of them actually do not have bronchospasm. So, nebulization actually has not been needed from what I am given to understand from a lot of centers in Bombay, at least, who are treating ICU COVID-19 patients. So, what we are going to do is primarily look at COPD exacerbations for who are going to require bronchodilators, and I think they seem to be doing as well with inhaler and spacer as with conventionally with nebulization. Of course, whatever Swapnil has said, to restrict the irrational use of nebulization unnecessarily.
Yeah, absolutely. Next question is by Dr. Neeraj. How to differentiate influenza from COVID-19? As we all know, there are a lot of overlapping features between influenza and COVID-19. So, even if there are a lot of overlapping features, common features to COVID are common symptoms to COVID are dry cough and breathlessness, which are least commonly seen with influenza, seasonal flu, and the running nose, sneezing is commonly seen with influenza. But there are, as I said, there are a lot of overlapping features. So if you at all want to differentiate, the testing is the only way to differentiate it. Simultaneous testing will definitely help if you are suspecting swine flu or H1N1 also, along with the COVID-19 testing. Okay, moving to next question by Dr. Mrunal. Can clothes act as fomites? Dr. Mrunal from Kolkata is asking, can clothes act as fomite? Definitely, yes. Not only clothes, but all other accessories like your cell phone, rings, spectacles, stethoscope, shoes, etc. can act as fomites. So where I would suggest where minimum or least possible accessories. Use alcohol-based sanitizers or disinfectants to clean your cell phones, your spectacles and other accessories if possible. And if you have a facility, then take bath. Sorry, am I audible?
Yes.
Whenever you have whenever you have facility at your clinic or your hospital, after doffing or after finishing your work, if possible, take bath at your hospital or clinic only. If not possible, when you go home, remove your shoes, other accessory outside as far as possible outside your home. Preferably keep it in a Ziploc bag and then enter your home directly to a bathroom to take a bath. So those things we can do to prevent getting COVID droplets or infected droplets at your home and to prevent transmission to your family members. So next question, Dr. Beena Upadhyay is asking, how long do the micro droplets from cough will hover in environment and virus persist in air? There is one, I would say there is one interesting article just published in NEGM recently regarding the viability of COVID-19 in air and airborne transmission. So it suggests that persistence of COVID-19 in air at 3 hours after generation of aerosols in a controlled environment. They used a high-powered machine to generate aerosols, and in that controlled environment, they checked after 3 hours whether the virus particles are present or not. And shockingly, they found that even after 3 hours, there are some virus particles or droplets less than 5 micron in size, which were present in that environment. But we should not fear, as this is a high-powered machine. It does not correlate or does not relate to the normal human cough mechanism or cough condition. And the analysis at China, where around 75,000 cases were studied, where they found that airborne transmission was not at all reported. So till date, there is no evidence of airborne transmission. Next question is for you.
Yeah. So the next question is from Dr. Neeraj Gupta. And he basically says that when lockdown opens and won't the airway disease exacerbation will increase, and how will you rule out COVID? So I think that is a concern that almost everybody has, that once lockdown is released and there will be more interaction with people, we are going to have patients who are going to present increasingly with more symptoms. We will have to treat each of them as suspects and do the standard care to rule out a COVID infection. So you're going to treat all exacerbations, all admissions, all emergency admissions to the hospital as COVID suspects, keep them in a different area, use appropriate precaution, at least grade 1 PPE, if not a grade 2 PPE, send this oropharyngeal and oral swabs, and of course the investigations that we already discussed in my presentation, which was basic investigations like CBC, see if there is lymphopenia. So what is being seen is with COVID-19 infections is usually the WBC count is somewhere between 3,000 to 4,000 is what is a trend that is emerging even from our country. So that is one thing that can help us figure out you have a high CRP, high D-dimer, high ferritin levels, high LDH levels. These are all going in favor of a COVID-19 infection. So these are some things that will help us differentiate between a COVID-19 versus other causes of exacerbations. The next question, I think, is why should chest physicians not examine patients in open spaces? Is there any face mask which can prevent infection in chamber of doctors by coughing and sneezing? So I think, Swapnil, you may have already covered this in your presentation about face mask which can prevent infection. But I think there are many chest physicians, what they are doing is that they are, if you see, most hospitals have set up their screening OPDs in the area outside the hospital near the emergency room, which is a makeshift cabin, which just has walls and it has an open space on the top, or it's like a high tent. Like what we see in weddings, it's a high pandal. With open spaces, with fans and natural ventilation without air conditioning. So definitely not examining patients in closed rooms and not examining them in air conditioning rooms will definitely decrease the risk of our exposure and transmission from patients to us.
Okay. So should I take this question, ma'am?
Is there any role of cephalosporin?
Role of cephalosporin.
Yes. So I did mention that you are in COPD exacerbations when you do require antibiotics. The amoxiclavulinic acid, third generation cephalosporins like ceftitorin along with azithromycin would be an important combination that you would cover for exacerbations, to cover bacterial infections, to cover atypical infections, and of course, because azithromycin has shown to have some role in treatment for COVID-19, it will probably have some effect in that as well.
Yeah, and I would like to add one thing, since now there is a lockdown and the patient finding it difficult to get to the clinic. Ceftriaxone is third generation cephalosporin, which is available in oral formulation. So that is an added benefit of it.
Absolutely.
Yeah. So,
Yeah. So I think the next question is what we are talking about is when somebody has asked, when switching from third generation cephalosporins like cefotaxime, ceftriaxone, parenteral therapy to oral therapy, will ceftriaxone be considered useful considering similar spectrum of activity? In fact, Dr. Sanjay, I would like to reiterate that if a patient is not severely breathless and acutely requiring hospital care at present, we should try and manage all exacerbations at home. And I think, I don't know, I mean, what does Swapnil have to say, but I'm realizing that many patients are actually not having that kind of mild to moderate exacerbations. Most of our patients in the first week of lockdown, patients were still calling up, with exacerbations of ILD, exacerbations of asthma and COPD. But since last week, we are seeing lesser patients with exacerbations of these diseases, and what we are seeing in hospitals is what is probably turning out to be more of COVID rather than other exacerbations. What do you say, Swapnil?
Definitely. I agree. I could see there is a lot reduction in patients with acute exacerbations. Maybe maybe the benefit of lockdown, benefit of there is a less air pollution nowadays, and obviously community. There is a social distancing, so community acquired pneumonias are also less.
Okay. Is radiological finding a confirmation for COVID-19 when RT-PCR is negative? So there is some data to suggest that when you have peripheral basal predominant ground glass appearance with septal thickening, is a finding that is going in favor for COVID-19 infection. However, this needs to be in the right context and the right clinical spectrum. So you have to have a strong clinical suspicion of COVID-19 with these CT findings. Then you would say that the patient could be a COVID this thing. Of course, nothing is confirmatory. I mean, you cannot substitute a RT-PCR for any of these things. But this is when your RT-PCR is continuously coming positive, which we are seeing in some patients that who are admitted as suspects. They have even 2 or sometimes even 3 swabs negative, but they do behave, like a severe acute respiratory syndrome, become hypoxic, go on the ventilator, and when their CT scan is done, they are showing patterns which have been now described as what is called as highly suggestive of COVID-19. Swapnil, you want to take the next question?
Yeah. Yes. So there's some issue with my internet connection. Can you take it?
Okay.
Yeah.
So what the next question says, do I need to get quarantined as I'm a health worker? One of our staff has contact with her friend at hostel who got exposed to corona positive at a hospital, probably on tertiary contact. So I don't know what is the sequence of events, but has your staff been tested positive? And what is the evidence of contact? So there are levels of contact. Is direct contact, wherein you have been in close contact with the person. So, if you have just met the person without touching them or been in close contact, have maintained adequate distance without direct hand contact or direct fomite contact to the same surfaces, then just having met the person is not a prerequisite to go into quarantine.
Yes, absolutely. There is one question. Can you give diagnostic tips, advice and guidelines for GPs who should be on the lookout in their clinics? By Dr. Kishore Ganatra. Yes, sir. As our Ministry of Health and Family Welfare guidelines and ICMR guidelines says, if you are anticipating any contact with the suspect COVID or proven COVID patient, then at your OPD level, you should use N95 mask and gloves at least. And apart from that, we had gone through the different symptomatology pertaining to COVID. Travel history, typical symptoms, contact history are the points which clinch the diagnosis. And those are the patient who needs to be subjected for testing.
If I can add something to that, Swapnil, I think typically
Yes.
in smaller towns, GP clinics are very crowded. So one thing to maintain right now is to ensure adequate patient distance between two patients. Is what
Absolutely.
is to avoid overcrowding, to ensure that the appointments or you see lesser number of patients per day, so that you decrease exposure to patients because of another patient and exposure to yourself as well.
Yes, absolutely. So, one question we missed,
I think
Doctor. Yeah, ma'am, continue.
no. I think you already took this question now. How to differentiate
Yes.
influenza and COVID-19?
Yeah,
Yes.
right.
So we can move to the next question. Swapnil, I think maybe you could answer that.
Can we use Z kit or even raincoats in case of shortage as PP? Dr. Sagar More is asking. Yeah, Z kit is absolutely, but we need to modify it. We need to find some jugards, Indian jugards. So Z kit, basically you need to cover everything. So use Z kit or even raincoats, but cover everything. Use N95 mask, use face shields, use proper goggles, use shoe covers, etc. So cover everything. Using mask, fit test is very much important. So if you're using N95, using surgical mask, do a fit test. After wearing properly, blow inside that mask and see if there is any fogging is occurring or not. And that's it. Cover everything. Madam wants to add anything.
If there is any fogging, the other thing that we are doing at Bombay Hospital is that we are putting a micropore to seal it off, in case there is any leak, because otherwise that causes a lot of fogging of the goggles and then you can't see anything. So that is one practical thing that we are needing to implement. So the next question by Dr. Rashid is whether there is fecal-oral transmission possible. Well, there is some data which suggests that there is the presence of virus in the feces of patients for many days, even after they have turned negative. However, at present date, there is no evidence to suggest that there is fecal-oral transmission from human to human.
Yes. One question we missed by Dr. Naveen. Is 6 feet distance is enough? Frankly speaking, 6 feet is a very arbitrary cutoff. This came from a few studies in 1930s and 40s. And it is based on the fact that droplets being heavy particles, they usually settle due to the effect of gravity within 3 to 6 feet distance from its generation. But there is one case study, recent case study at Washington, where they found a group of singers. They met for 2 hours at the beginning of March. 2 hours practice in every day, 2 hours practice, and no one was symptomatic, no one was coughing or sneezing. They followed social distancing as per their, as they said, but still, all said and done, 45 people become infected by COVID-19 after 15-16 days, and two of them have died. So I would say, even if this 6 feet distance is there, we should avoid as much as possible meeting other people. Social distancing, avoid social gatherings. That's why this justification, that's why this lockdown, extended lockdown is justified by our government. There are few reports which are coming that even the droplets can travel beyond 6 feet. It depends solely on the temperature, the air velocity, and the humidity of that.
So there is a question about what is better, oropharyngeal or nasopharyngeal swab for COVID infection. So the amount of virus which is there in the nasopharynx is much higher, which is why the ideal sample is nasopharyngeal. However, most labs, for increasing the amount of load that you can collect, you are collecting both nasopharyngeal as well as oropharyngeal swabs. So the ideal testing would take a swab of both. However, the concentration is much higher in the nasopharynx than in the oral cavity.
Next question by Dr. Sandeep. WHO recommends use of N95 only in procedures involving aerosol generation and not otherwise. What is your take on it? Yes, Dr. Sandeep. According to WHO, surgical masks should be used except in situations where there is aerosol generation takes place, the procedures where aerosol generation takes place. But our ICMR guidelines, our Ministry of Health and Family Welfare guidelines, even European CDC, Italian health guidelines, they all mention that for doctors, for us doctors, even if you are attending clinic where you are anticipating any COVID positive or suspected COVID patients, then you should use N95 mask along with gloves. For common people, definitely yes. No need of N95 mask. They can use surgical mask or simple cloth mask, homemade cotton mask.
There is a question from Sagar More which says that should we do COVID testing in all fever cases other than SARI? That's an interesting question, Sagar, because if you look at the ICMR criteria, so they have still classified the criteria for testing very stringently in patients who are who are in contact with known positives or who are symptomatic healthcare workers. But they have now included patients who are in the cluster zones and in the containment zones. So I guess in those zones, all patients with fever, even the ones who don't have associated severe acute respiratory illness, would merit a testing.
Yes. How effectively is pneumonia vaccine for old people? From Dr. Vishnu Kumar. Yeah, pneumonia vaccine, we know the pneumonia vaccine is recommended for older population. It covers pneumococcal disease. Its role in COVID is, there is no role in COVID, preventing COVID infection. What is herd immunity, Dr. Dhananjay? So herd immunity is the immunity which a larger proportion of population acquire when it is exposed to a certain epidemic or pandemic. But at least for the herd immunity to develop, at least 60% of the population needs to be infected. So we cannot afford to wait till herd immunity develops in India.
So the next question is, is hypokalemia a common finding in COVID-19 patients? I have observed it in 5 to 6 lab confirmed patients. What other findings we get in our routine investigation of suspected patients? Interestingly, I don't know, from the patients that I have seen, in fact, I have seen more of hyperkalemia rather than hypokalemia. So I'm not really sure, whether there is widespread evidence for this. We will have to probably look into it further. Other investigations, I think I've already covered in my talk, so I don't think we need to go into it again. So, is there any role of taking HCQS prophylaxis for healthcare workers? So, there's a lot of debate on this. Our Indian guidelines say that HCQS should be taken as a prophylaxis for healthcare workers, but there is also evidence, and there are papers suggesting that there is limited evidence on that, and there are also major adverse reactions that can happen with taking HCQS. But however, our ICMR guidelines does recommend taking HCQ for patients, which is in a dose of 400 milligram BD on the first days, followed by 400 milligram weekly for 7 weeks. So I guess it would be a very individualized call about taking it, but I would recommend that if you have concomitant cardiac diseases, or if you are old, then you would probably benefit with doing a baseline ECG.
Yeah, Dr. Sagar Ambekar is asking, can we reuse N95 mask? When reusing N95 mask is recommended, but not the preferred method, as they are not made for it. But since there is scarcity of the mask, there's one interesting method, interesting SOP for the use of N95 has been published. They ask you to borrow 4 masks use label it 1, 2, 3, 4. Use first mask, keep it for air drying on day 1, and reuse that mask again on day 5. Similarly, you can reuse other mask after 4 days or so. But as far as possible, it's not preferred. I can't hear. Hello. Should everyone wear mask? The next question is that. Yeah, WHO had previously said mask is to be worn by symptomatic people, caregivers, and healthcare workers. But last week only, CDC had come up with a guideline saying everybody should wear at least a simple cloth mask when they are stepping out of their home. So this is based on the knowledge that a COVID-19 infected person starts shedding infected droplets even 2 days prior to the onset of symptoms. So everyone who wants to step out of house should wear mask.
When to do bronchoscopy in COVID patients? Big matter of controversy. I think most units are forming their own protocols to avoid bronchoscopy in COVID patients because the risk of aerosol spread is going to be high. You're going to have to open the circuit to do a bronchoscopy, and of course, scope disinfection is also another issue that is going to come up unless you're going to use disposable scopes.
Yeah, I think this is the last question. Dr. Ajay Yadav, can we have leukocytosis and lymphocytosis in COVID-19? The evidence, whatever studies are there and whatever papers are there, they found out that leukopenia is more common finding, followed by normal lympho or leukocyte count. So these two are the common finding. But yes, we can get in some patients. So, you want to take the last question, madam?
Do we have a last question or there are many more questions?
Yeah.
So what is the cause of hypoxia, pulmonary embolism or ARDS? So I think this is a matter of debate, and there is evidence that is coming out from other countries where they are seeing that on post-mortem there is peripheral microvascular infarcts which they are picking up on post-mortem in these patients, and hence the whole discussion on whether we should be using anticoagulation in all patients with ARDS. But there is also, at least what we are seeing in some facilities in Bombay in the ICU are that even without anticoagulation, some of these patients are tending to bleed during intubation or even during inline suction. So I think there is no clear-cut answer to this. Yes, from other countries there is data, but I don't know what is the data from our country as far as microvascular peripheral infarcts is concerned in these patients. The one thing is certain for sure that in our country, at least in Mumbai, patients who are who have the cytokine storm and are being treated with anti-IL-6 are definitely doing better than other patients who are being managed with standard ARDS protocol. So some centers have had the opportunity to use tocilizumab in few patients, and those patients seem to have done much better.
Okay, so I think we should wind up now. I would like to again thank Team Zuventus for making this happen, Mr. Allad Mahazani for your constant support, and everybody who logged in, who interacted with us. Dr. Pratibha ma'am, thank you everyone.
Thank you, Swapnil. I thank everyone on
both of you did fantastic job.
Thank you, Meenal. Thank you, Allad. Thank you, Agam. Thank you, Dr. Krishna and Narayana. Bye. Hope to see everyone safe and sound soon.
Thank you.
Thank you. Both of you did fantastic job, and I thank the Chess Council of India and all those who logged in and bombarded us with so many questions. Thank you all for your support. Again, I thank Zuventus for giving us the platform and giving us the opportunity to discuss this particular topic across. Thank you very much. Thanks, Krishna.